is next person I will invite Professor Dr. B.S. Das, complications of anterior cervical spine procedures, management and avoidance.
Complications of anterior cervical procedures, management and avoidance. The talk for me is confined to the subaxial spines. Anterior cervical discectomy came into force with advent of the procedure by Smith and Robinson in 1955. Very soon Cloward joined, and it was a change of an era from posterior approach to anterior approach. Era of anterior versus posterior approach continued for quite some time. Late 70s and early 80s, gradually surgeons changed over to anterior approach. Anterior cervical discectomy, often done with fusion and without fusion. Many people say the results are similar. Anterior cervical discectomy and fusion, autogenous bone or implant is taken. Anterior cervical corpectomy and fusion, it involves a long segment. Quite often instrumentation has been used. And then the era of instrumentation has come into existence. Many complications are known. I'll just mention certain common ones. Dysphagia is a very common complication. Multiple level surgery, reoperations cause dysphagia more often. When it needs retraction of the important structures like esophagus, trachea to one side, often superior laryngeal nerve involvement adds to the problem. Hence, proper plane and gentle handling would help to overcome this situation. Endotracheal cuff pressure of 15 mercury is considered to be the most ideal and prevents dysphagia. Steroids help in recovery. Esophageal injury. When a large segment is being operated, and particularly with long retractors, esophagus may get involved. If it is detected during surgery, it's best repaired. Now, delayed detections may lead to hematoma formation and infection. These small cases can be managed with tube feeding and may need construct removal if so required. It's best avoided. Recurrent laryngeal nerve palsy is one of the problems, and it presents with dysphonia. In prospective studies, it varies from 0.8 to 5%. Cause is stretch or cut of the nerve during surgery. The stretch ones do improve over time. If it is cut, it doesn't improve. Other means have to be there to manage the situation. Most of them recover, and that is either stretch injury has been recovered or the vocal cords get adjusted. Common damage is a concern. Post-operative hematoma, as in any operative condition, hematoma is a not welcome situation. Now, in this case, superior thyroid artery source, bone or muscle could be the source. Now, if it is a rapidly occurring after surgery. It could be life-threatening certain situations. So that will need immediate reoperation. Swelling of the operation site, dysphagia are the early symptoms. Serosanguinous discharge may indicate there is some collection. Early detection, evacuation, and if necessary, reoperation are the remedies. Implant failure and graft extrusion. Present time, use of implant is very frequent. I shouldn't say beyond it, but it is very frequent. Now, quite often, what we say with us, we get a full tray from the company. It may be lacking the particular screw one needs, and that is the problem. So, screw breakage, pull out, screw loosening, plate fracture, graft migration are the situations which would cause implant failure. So one has to be careful to take the suitable implant, and there should be no compromise in the size, length, shape, and quality of implant. CSF leak. To achieve CSF leak, one has to cross the dura and subarachnoid space. It's not common, but it does occur. In a large segment of OPLL removal, the dural injury becomes obvious and it may be possible to repair it because available. Now, in interbody disc spaces, one may not see it properly and try to close it either with muscle, blood patch, or hydrogel. Any of these can cause pressure on the underlying nerve. So that has to be kept in mind. It's best treated by CSF drainage, continuous drainage, but look out for infection. Well, infection is dreaded for everybody, every surgeon, everywhere, anywhere. Please look after the patient's comorbid state, like anemia, hyperproteinemia, etc., prior to decide to operate. CSF leak and hematoma are preludes to it. CSF infection may lead to many undesirable complications. Suitable antimicrobial therapy, deep space collection should be. In the miscellaneous group, I have put spinal cord injury. It is difficult to achieve, but it can happen with a bad luck. Vascular injury, like carotid artery injury or vertebral artery injury. And these two are have to be attended. Carotid artery injury has to be attended because it is obvious. Vertebral artery injury, you can patch it and control it, but some of them develop later on pseudoaneurysms, and that need to be treated by endovascular surgery. Horner syndrome, adjacent segment disease are no. Adjacent segment disease is commoner when there is short segment fusion. It is less common when it is a long segment fusion. But when it occurs, it to be addressed in its own merit. After describing so many complications, small, medium, graded, and so on, I have a small advice to all, including me. Please know your patient prior to surgery. And this patient should also know you. plan the surgery. Not that let's go and have a surgery of such and such case. Each case is a patient. Don't compromise with the quality of implants. Take a helping hand. Don't go alone. Situations like vascular injury, help should be available under the same roof. There is nothing like EG, spinal surgery. Each one has to be regarded in its own merit. Thank you for patient hearing.
You are muted, PD. You are muted. You are not heard.
Sorry. Thank you, Professor Das, for the nice lecture, nice talk, and elaborating all the common complications we come across in day to day life. And I agree with you very clearly that talking to the patient, understand your patient is a very important point, and you should see the patient, and patients should see you, because now, because of this corona, a lot of things were done on telephone and nobody was knowing what's the patient. We just talked on telephone and brought the patient for operation. Of course, this is going to go down slowly, but that is what has happened. But I take your point very seriously. um, any questions?